Hey, it's Abdul. Welcome to this video on familial dyslipidemias. Now, as a general rule, dyslipidemias are going to be lifestyle related most of the time. And obviously, you're going to see this more in step 2, but sometimes that's not the case. And usually, the biggest clue is when the question stem or the clinical vignette starts emphasizing a lot on the history, the family history of the patient, bringing up a lot of familial conditions. Now, this is probably the first trigger that what you're dealing with now is one of those familial dyslipidemic conditions. Now, there are 5 diseases that we will be covering in this video, and each of them represent some aspect or some portion of the lipid transport system not lipid transporting anymore or properly. Now, the first one is type 1 hyperchylomicronemia. This is an autosomal recessive condition associated with very, very high levels of triglycerides. Now, looking back at the central physiology of what's supposed to happen, a chylomicron or a VLDL will bind to an LPL receptor via its APOC2, and then that will catalyze the breakdown of its triglycerides, and then it will dump those free fatty acids and glycerol to the peripheral tissue, whatever it may be. Now, in this condition, there is a problem, either at the level of an APOC2, for example, a deficiency in the APOC2 receptor, or a deficiency in the LPL receptor. Either way, this patient will present with this same kind of spectrum of conditions. Now, the most common clue that what you're dealing with type 1 is going to be a patient who comes in with recurrent pancreatitis. Very, very high levels of triglycerides are one of the causes of pancreatitis, and these patients will present with repeated episodes. Now, another clue is eruptive xanthomas. This is going to be due to the triglyceride accumulation in the tissue, such as the skin. This is an example of an image down there. Now, very importantly, type 1 is not associated with atherosclerosis. There is no response, there is no elevation in LDL levels. The problem is just elevated triglycerides, so there is no role in atherosclerosis. Moving on to type 2, hypercholesterolemia. This is going to be an autosomal dominant condition where patients will present with very super duper high levels of LDL. Now, this could be either due to a problem with the LDL receptor or a problem with ApoB100 or PCSK9 mutations. The overall cause is that it's going to be associated with very high levels of LDL. Now, in this condition, in contrast with type 1, it is associated with atherosclerosis. The questions then might give you a history of very early onset myocardial infarction, like in their 20s or their mid-20s or 30s. This is not normal, and that's a clue that this patient may have a type 2 dyslipidemia. Moving on to type 3, dysbeta lipoproteinemia. This is an autosomal recessive condition where patients will have both elevated chylomicrons and VLDL. The main issue here is that it's going to be due to a defective APOE. If you remember, APOE is important in how chylomicron remnants are absorbed back into the liver. Now, without that, they kind of stay in the systemic circulation, and that will increase their amount. Now, these patients will present with premature atherosclerosis because the VLDL is affected, and they also will present with tubero, eruptive, and palmar xanthomas. And finally, you have type 4 hypertriglyceridemia. This is an autosomal dominant condition where you have elevated VLDL levels. Now, here the issue is that the liver is going totally cray-cray. It's ramping up production of VLDL at crazy amounts and dumping that into the circulation. So that's the central pathogenesis. It's an overproduction problem. These patients will present with recurrent pancreatitis as their core clinical manifestation. Now, A-beta lipoproteinemia is a bit different. It's a hypolipidemic state. The others were all hyperlipidemia. This is a hypolipidemic state. Here, the problem is either you have an absence of ApoB100 or an absence of an ApoB48. When you have an absence of ApoB100, VLDL cannot be released from the hepatocytes, and when you have a deficiency of ApoB48, again, chylomicrons cannot be secreted from the enterocytes. The net effect of that is that you will have absence of chylomicrons, absence of VLDLs and LDLs from your circulation. And this is called A-beta lipoproteinemia. These patients will present with a clinical picture of severe fat malabsorption. Initially, this may be with steatorrhea, but eventually these patients will develop fat-soluble vitamin deficiencies. And the USMLE loves that because they can test you on vitamin deficiency symptoms via a patient presenting with A beta lipoproteinemia. And with that, we wrap up this video on familial dyslipidemias. Do let me know in the comments below if you have any questions or if you have any videos you want to see next. Thank you so much for listening, wishing you a wonderful day, and see you later.